Change. The word alone can be challenging. How do we get started? Where will the change lead? Don't sit there and worry about it. Be the change. Welcome to Be the Change Radio. Host Christina Bloom has been a professional psychic and spiritual advisor for 20 years, offering psychic and mediumship readings for individuals and groups. She also teaches several classes in psychic development and metaphysics. In addition, she is an author who has published 2 books so far and is the co-owner of Moonbow Publications and Productions, LLC. Are you ready for that change now? Here is your host of Be the Change Radio, Christina Bloom.
Hello, everyone, and welcome to Be the Change on WLTK-DB Talk Radio with Christina Bloom. I am obviously not Christina Bloom, so my name is Matt Anderson. I'm a physical therapist, and I've had the privilege of being on the show a few times here with Christina. And she is taking the week off after having her son Logan's celebration of life. So she's just taking tonight's to rest up, and then she will be back with everybody next week. So she says hello and sends everybody her best wishes, and will be returning shortly. So tonight I get to talk with you on chronic pain. So an area that I specialize in. Just a reminder, again, I'm a physical therapist. I specialize in manual therapy and primarily work with pain, both acute and chronic, but lots of chronic conditions, mostly neck and back pain, and then some other more complex issues too. Area that I just find really fascinating, was very, very challenging, certainly when I first graduated from college and started working with patients. But you know, when we're faced with the easy road and the hard road, some of us are a little special in the head and will take the other direction and run right to the fire. And that's kind of what I did. And I liked the challenge of it, and saw that there was so much potential to do more and to learn more. And that really was what ignited the passion for me to go down this path. So that is my background. So I have a private practice. My clinic is called Vistara Health and Wellness. My website is vistarawellness.org. It's Vistara. If you want to reach out to me, certainly feel free to do so. I have my contact information there as well. And so far we've got Robin. Hello, welcome. And anyone else, if you're joining us, feel free to make a comment. Let us know you're here. And Christina will be back again, like I said, next week. She'll share any announcements that she has for you then. Lee is joining us. Hello, good evening to you. And so pain, let's talk about it. Pain is no fun, obviously. And you know, it's a really dynamic and complex issue, whether it changes from the simple, obviously, if you stub your toe, that doesn't feel good. That's your acute pain. Then something that happens in the short term, and you have that immediate onset of pain, and then hopefully in a short period of time, it fades and subsides, and then you are feeling better. Welcome to Resnick and Jessica. Thank you for joining us. And so then what chronic pain is, and we talked about this on a previous show a little bit, but just to kind of lay the foundation. The average, what determines acute versus chronic pain is there's a certain time frame, which is 4 to 6 weeks on average, and that's what it takes for, if there's tissue damage, for healing to occur. So if you cut yourself, or you have a surgery, or say you sprain your ankle, in terms of any damage to the skin, the ligaments, the muscle, there should be a pretty good amount of healing that occurs within that time period. So in theory, based on that, the pain that a person's having from that injury should have subsided by then. Unfortunately, for some, even after the tissue is healed, they continue to have pain. And that is when you're getting to that 6 weeks and beyond. And when that pain continues, then that's, especially when it continues beyond that acute trauma, or where you're dealing with the tissue healing aspect, that's when we're getting into what falls under chronic pain. And for some people, that unfortunately can carry on for years. And with chronic pain, it's a pretty dynamic thing, because chronic pain can be something where the person had the issue, or you had an injury and it's healed, but you continue to have the pain, or things like a degenerative issue in your spine. Let's say someone has really bad disc issues, or they've got some arthritis in their back, and just their back is kind of worn out and not doing so hot, and then they have that ongoing long-term pain because of it. That also would fall under the definition of chronic pain. So chronic pain can also just be from worn out body parts, and areas that we're just struggling with. And what is interesting with it is just that chronic pain is really, really tough. Of course, it's hard for the person experiencing it, but it's also really a struggle for medical staff to treat. Speaking as as a healthcare provider, it's hard seeing your patient in pain. I mean, most people that go into healthcare do it with the intention of wanting to help people live their best life and feel better. And certainly, our desire is to, when somebody's in pain, any compassionate, caring person wants to do everything they can to try to alleviate that pain and take it away and help the person feel better. And chronic pain it's not easy, and sometimes no matter what you do, that pain continues. And of course, with that, the individual experiencing it gets very fatigued, and it gets at times desperate, and just really, really desperate, seeking that outlet and trying to find relief and a way out of that. And that can be a really tough one. And when you're dealing with people that are in a really challenging state, it's tough for the provider as well. And sometimes it just leaves people grasping at straws, trying to do anything and everything they can to bring relief. And unfortunately, the overall general approach in terms of what we have to work with and kind of the standards of what care is in these instances, it's not very good. And the statistics for managing both acute and chronic pain also not good. And so many people are aware of we call it the opioid crisis that has happened here over the last. It's really starting to subside some. Hello, Courtney. Thanks for joining us. It's really started to subside here a bit now these last couple of years, just because it did become a very pronounced issue where the amount of prescribing of opioids, which narcotics, that's what that is. So the stronger prescription-based pain medication was getting out of control. And when this was being studied and tracked, looking at trends within our country, and certainly compared to other developed nations, the U.S. was, I don't remember some of the stats now. It's been a bit since I've looked at them, but it was incredible. The percentage of the overall pain medications prescribed in the world were extremely disproportionate to how much of that was coming from the US alone relative to what's in every other country combined. We were leading it substantially. It was a really, really high number. And what we were finding from that is people were not better for it. In many cases, they were worse. I've seen it again and again with my patients, and thankfully it is improving some now. But what was a typical presentation is somebody would go to their doctor and say, I was working in my yard and doing some yard work, and I bent over to pick up a branch, and I had this sudden sharp pain in my low back, and it spasmed, and I've really been struggling since that time. And so they go in to see their doctor, and doctor says, okay, yes, definitely. I can see you're in pain. I can feel that your back's really tight. I can see you're not moving well. So let's try to get you more comfortable. So common things, they'll look at anti-inflammatories, and then oftentimes a muscle relaxer. And then also will often, then when needed, pain medication. And so then they'd often prescribe pain medication, be a little more generous in that acute phase. It can be pretty nasty and pretty intense pain. And then say, okay, take this for 2 weeks, and then let's follow up. Or if things haven't improved in that 2 week period, let me know, follow up, and we'll go from there. And so then what was happening in some cases, certainly not all, is people would come back 2 weeks later, and then, okay, my prescription pain medication has run out now, but I'm still in a lot of pain. There's no way I can be without it. So then doctor would say, okay, we'll renew your prescription and give you more for a longer period of time. And then, at this point, let's look at, we should probably do an X-ray or do an MRI, maybe look at referral for chiropractic, physical therapy, possibly seeing a pain specialist, and getting the ball rolling. And then say, okay, we're going to follow up in 4 weeks. Well, then 4 weeks later, they come back, and in some cases, they say, it's not any better, and if anything, it's actually gotten worse. And then they look and review everything. It's like, okay, your X-rays show that there's no signs of fracture. There's nothing significant there. And your MRI, yeah, we see some wear and tear, some bulging disc, but that's pretty common. That's pretty normal. And we're seeing some arthritic changes and wear and tear, but again, we expect that. So that doesn't quite support the level of pain that you say you're experiencing. And by the way, your injury was 6 weeks ago. Anything that you should have had in terms of an injury should have been pretty well healed by now. So I am hesitant to give you more medication, or they were giving them more. And it went either way. And then at this point, many were adding additional meds and say, okay, we're going to keep you on the pain medication, but now we're going to add this prescription, or we're going to add another prescription, and then try to get them in to see specialists and keep escalating things. But then that time continues to go on. And oftentimes they have increased the amount of medication used during that time. And then finally it gets to a point where it's just, whoa, it's been way too long. You're on way too much medication. There's no reason you should be having this amount of pain. And I can't give you any more. Or I'm going to refer you to a pain clinic or a pain specialist, and they're going to take over management of your medication. And so that was a common thing. So they would continue to prescribe what was needed until they could get into a pain program, a pain clinic, and which are led by physicians, PAs, nurse practitioners. And then at that point, many would get into what they call a pain contract. So they verify everything, look at what is the appropriate amount of care that this person should be getting, what are their options, and then if they haven't, a great time again to look at physical therapy, chiropractic. Sometimes they'll even be as progressive as to mention acupuncture, and then just start putting other things into play. But then, okay, now we'll look at getting you on a regular, ongoing pain medication regimen. And with that, they would actually have to sign a contract. And with that contract, you have to agree that you're only going to take the prescribed medication only. You're going to take it as prescribed. You're not going to take anything else, including any illegal substances. And then you're subject to random drug tests. And they just say drug urinalysis. And what's interesting is not only would they look to see, do you have drugs showing up in your system that have not been prescribed, but if they have prescribed a pain medication, it should be showing up on that test. So one of the things that happened during this whole crisis that was a factor there too is as people were getting more and more desperate and looking for that pain medication, especially if they weren't able to get prescribed as much as they felt they needed and wanted, then it definitely became an issue of obtaining it illegally and buying it on the black market. And so there was a time where there were even people that were paying individuals to go to their doctor, and they would give them a script, and this is what you need to say, this is who you need to see, and everything you need to tell them, and they're going to give you this med, and you're going to get that prescription filled, you're going to come to me, and I'm going to pay you so much per pill. And then they become the drug dealer and sell it elsewhere. And so that was an issue too. And ultimately what happened then is this was identified as a major problem. Another side piece that came in there too was this was spearheaded in part by the American Medical Association and the CDC, so the federal organizations, and then the American Medical Association is not federal, but certainly one of the largest, most robust organizations that influences our healthcare in the U.S. And another issue that was happening with the prescription pain medication is a lot of them also had acetaminophen or Tylenol in them. And what many providers would tell their patients is, okay, you get so much of your hydrocodone or OxyContin, Vicodin, all the different ones that are out there. And if that isn't enough to address your pain, then the next thing you should do is just take Tylenol. And so then people are going to the Tylenol and they see, okay, it says maximum dosage is X number of milligrams and tablets per day. So they were taking that, not knowing that there was also the acetaminophen and their other medications. Well, then we started seeing issues with people overdosing and having kidney and liver issues because of taking more. They were exceeding the recommended daily dosing that has been proven to be safe through the research. So all this came together, and so they reformulated a lot of the medications to reduce the amount of acetaminophen in it, but then also reclassified some of the drugs. Um, Vicodin, for instance, used to be given out constantly for a lot of different things, and you don't see that near as much now as we used to. So that was actually there's a schedule that it's called, and things are classified at different levels based on the amount of risk for the patient, and then also factors of is there a risk of being addicted, and this becoming something that is more serious and needs to be monitored more closely for patients using them. So that was all reformulated, and then they also created a national database where the prescribing patterns of anybody, any physician, PA or nurse practitioner, anyone that has script privileges, they can track the amount of medication that pain medication that they're prescribing, and then compare it to national trends. So what it was doing is it was identifying people that were being way too liberal with the amount of medication they are prescribing. And then that also created some fear among providers, because then, I mean, the federal government was reaching out to them, and their medical license was on the line. And some that were identified to definitely be determined that this was outside of the appropriate standards of practice did lose their licenses, and clinics were closed. Uh, and so then now what we're seeing, which is common, is anytime there's an issue, the pendulum has swung too far one direction, where it's too liberal, too getting out of control, but then it now goes the other direction, where now we're fearful of it, and now there's some where they're almost under prescribing in some instances when it really is appropriate, and that has definitely created some problems now too. So we're seeing that it's gone to the opposite extreme, and ultimately one of the things that was happening then is the person goes to their provider with concerns of pain, and they're given medication. Pain's not better. Okay, continue the medication. Pain's still not better. Okay, we're going to try increasing the medication. Pain's now worse. And they say, whoa, you've been on too much for too long. So now basically you're labeled as labeled as somebody that is drug seeking, and then they're going to monitor you very closely. Sometimes they'll wean the person and just cut them off their medication entirely. And now not only is their pain better, but some instances their pain's worse. And to add to it, they're addicted to a medication that has been taken away. And that definitely led to certainly the rise in seeing these drugs on the market illegally, where you can buy them from people that are not prescribing, and then also people seeking other street drugs to try to achieve the same effect. And it's definitely become a more significant issue, and continues to be. And with that, one of the things people may have heard of is Narcan. That's one of the medications. It's a counteracting. It's injected. So if somebody is suspected of overdosing on pain medication or drugs, street drugs too, such as heroin, that is what EMTs carry, and they will inject the person to counteract that, to try to hopefully save their life. And there's even been legislation now where they're looking at this being attainable over the counter. So even people that are using street drugs, that they can have it, or someone can have it in their household just in case they do overdose and have that ability to ultimately save their life. And it's a very touchy one, politically, that there's some resistance, and it goes each way, but it's a tough one. And then that's the whole medication route, with dealing with pain, and certainly with chronic pain. And the interesting thing is that in other countries, I mean, other comparable developed nations, they do not prescribe pain medication anywhere near like what we do in the U.S. In many cases, you're only given pain medication if you are in the hospital, with a new injury or with surgery, or for people that it's end of life, and it's a terminal thing for pain management. Anything outside of that, very rarely do some of these areas even prescribe medication like that. You're dealing with it with over the counter and other non-narcotic pain relievers. And just looking at a couple comments here. Someone mentioned, yes, the concern of the medication effect on their livers, and then drinking with it. That's certainly something that I have seen a lot, with some of my patients, that medication only does so much. And for some, drinking, consuming larger amounts of alcohol helps them sleep. It numbs their pain, it numbs their mind enough to where they can get that escape. And you can appreciate the desperation that leads them to it, but the concern is how harmful it is to their body, and where that can go. Let's see, another question about people who need pain prescriptions can't get it, it seems. Yes, we just talked about that a little bit, and that is another concern also, is that there are these instances where, I've had some patients that, when you've lived uh, a life where you've been very active, or certainly if you've had plenty of injuries, our body can reflect that, and you can have more significant wear and tear and arthritic changes and degenerative changes. And there are times where you hurt, and there's not a whole heck of a lot you can do about it, in terms of you can only do so much with surgeries and with treatment like chiropractic and physical therapy, and it gets to where we're looking for what else can we do to just try to manage the pain to maximize the person's quality of life. And that's becoming more challenging. And so, some of the things that are interesting when we look at pain and how what pain is what many are not aware of, is that pain, we don't have such things as pain receptors or pain nerves. What happens is, our body, receptors in our body, from things like light touch, sharp, dull, deep pressure, hot, cold, all of these sensations are sent from those receptors to the brain. The brain gets this information, and then the brain interprets that, and then the brain will determine whether or not that sensation should be interpreted as pain versus, say, light touch or deep pressure, sharp, dull. And then the pain ultimately is a protective mechanism. If, for instance, you put your hand on a hot stovetop, not knowing it's hot, and you feel that it's hot, okay, you're going to get a sharp pain response from that, and it says, take your hand off the hot stove. So obviously, it has a lot of value there in helping us to remove ourselves from a dangerous or a harmful thing that could cause more harm. However, the brain changes with chronic pain, and what will often happen there is it becomes hypersensitive. And so you have situations where, and I'm guessing some of the audience here has experienced it themselves. And if you haven't, it's very likely you know someone who has. And in some of these states, you can get to the point where logically, that light touch, somebody just gently touching your low back, or just gently touching your leg, should not give you sharp pain. That I've had some where even just wearing socks, they can't handle. Socks on their feet are just so painful, or they cannot wear shoes because just that compression from their shoes, the sensation of the shoes on their feet, gives them such sharp pain that they can't tolerate it. And so then you get to a situation where the brain's interpretation of that information coming in, such as just light touch from a sock, shouldn't be sharpshooting, intense stabbing pain, but that's what can happen. And so there's a change that happens where that threshold is altered, and the person becomes much, much more hypersensitive to any stimulation, where a lower level of stimulation will trigger that larger pain response. And one of the analogies that's commonly used is, think of climbing a mountain. And when you climb a mountain, and you think of it as your effort that you give. And okay, so you're going to expend so much effort to get halfway up that mountain, and then by the time you get to the top, you've given it your all and you are pooped and really tired. And so you expect the person to really feel the results of that increased effort at the top of the mountain versus, that halfway point. And we can think of our pain that way. So for instance, if you are, we commonly use a 0 to 10 pain scale for rating our pain, where 0 is nothing and 10 is the worst possible pain you can imagine. And let's say you walk down your driveway and you go to get the mail out of the mailbox, and you've got chronic low back pain. And just sitting, not doing much. I mean, you're already at a 3, 4, maybe even a 5 out of 10 pain. And then you walk to the mailbox, and now you're like, I'm at a 10 out of 10. I don't even think I can get back into my house. It hurts so bad. My back's locking up. My legs are spasming. I can't move. I'm stuck. And we know that in most instances, walking to the mailbox and back really shouldn't be a big problem. It shouldn't be that painful, especially when you know that there's no fractures, there's no broken bones, there's no significant threat of something being really seriously wrong in terms of the structure of the person's body. And in terms of chronic pain, the number one is low back pain. Low back pain has the highest incidence of becoming chronic pain. And so then what we deal with in those instances is, we look at, okay, I am at 8 out of 10 or 9 out of 10 pain just walking to my mailbox, walking to my end of the driveway and back. And from a medication standpoint, it's like, okay, let's try to see if we can prescribe pain meds to bring your pain level down. And it doesn't work that way for chronic pain. It does not have the same effect on chronic pain as it does on acute pain. What will often happen is, in order to get that level of pain relief, the person's on a pretty high dose to where it just kind of, you're left in a fog. A lot of complaints I hear from people of just, they feel like, I'm not clear in my mind. I can't think. I can't focus. I can't concentrate. I just feel so groggy. Like the pain's still there, but it's just like, I just don't care about it because I'm so out of it. I don't even have the ability to focus on what I'm feeling in general. And so that is a lot of what you hear when you're trying to manage chronic pain with the standard pain medications. So then one of the things that we try to do is, when you become increasingly more sensitive to pain and it takes less and less to provoke those higher levels of pain, is what can we do to try to set that bar in a different way? So instead of getting at that 10 out of 10 pain, uh, a quarter of the way walking up the mountain, let's see if we can get you halfway up the mountain before you reach 10 out of 10. And so you do that by gradual exercise and just continuing to work through what you can, and then try to just push it a little bit more, a little bit more, a little bit more. And you have to do it consistently. And then what happens is, your progress then is not so much focusing on pain as the marker or the measure of your success, but what can you do before you reach that higher level of pain? And so with my patients, what we'll start out with is, they'll say, okay, going to the mailbox is 8 or 9 out of 10. And I know that if I don't get back in the house and sit down, I'm going to be stuck and I won't be able to get up. Okay, we're going to start there. So we don't want to take you right to that 10 out of 10. We want to keep it within what's doable. So to start out with, hello, Nikki. Nikki is just joining us. Let's start out at walking halfway to the driveway, halfway down your driveway. And then let's say at that point, you're like, okay, halfway down the driveway, I'm at a 6 out of 10 pain. I'm really getting uncomfortable, but I can do it. Okay, we're going to do that. We're going to take you to that point and then come back and take a break and rest a little bit. And then a little bit later, let's have you get up and do that again. And let's try to do that 2-3 times a day. And then we're going to try to add that 4 to 5 times a day. And then we're going to try to get to 5 to 7 times per day. And then you just keep increasing it. And then, okay, now that you're doing that consistently and you can do that multiple times per day, almost every day of the week, now instead of going halfway, we're going to try to go 3/4 of the way. And then you do that consistently and you keep building to where you're doing it again and again. And then what will often happen is, okay, I was at 6 out of 10 pain going halfway down the driveway. Now I can go 3/4 of the way down the driveway before I feel that 6 out of 10 pain. And then each week with consistency and your activity level, you can try to build on it a little bit more, a little bit more, a little bit more. And then what happens is now I can go to the mailbox and I'm at a 6 out of 10 versus a 10 out of 10. And now I can walk down the street a little bit. Now I can walk around the block. Now I can walk 2 blocks. And then what happens is your pain rating in your daily activity comes down because you've conditioned your body to where you can tolerate higher levels of activity before you experience that high pain level. So you're changing your pain threshold based on the activity that you tolerate. And that is really the key that we found to be one of the more effective ways of managing chronic pain. Because with that, we're not so focused on just, I feel pain, pain is bad, get rid of pain, kill the pain. It's what can I tolerate? And how can I achieve the goals that I want in terms of my quality of life and what I need to do before I start to feel those levels of pain? And that is one of the most effective ways that we can go about long-term chronic pain management when you're dealing with a situation where you know the level of pain does not make sense relative to what's going on within the body. If you have somebody where they're dealing with a really worn out joint, or they do have a really bad back and there's a lot of stuff going on there, those are situations where you can still see progress, you can still see improvement, but you have to be a lot more cautious and a lot more careful, because if you do too much too quick, you're going to aggravate things and then it just can go south. And basically your body fights back and then it really flares up your pain. And then now the person's really struggling with even more basic activity. So we are about at the halfway point here. So I'm going to shut up for a moment and we're going to take a quick break and then we will come back.
Want to see your video here? Sponsor WLTK-DB Talk Radio and watch us make that happen. With your paid sponsorship of $80, you receive a professional produced audio, video, and banner placement on our station. Not only does your sponsorship air during our live shows, but also replayed on our podcast and heard by hundreds of like-minded people. Visit WLTK-DB.com to get started and find out just how hard we work to get you noticed.
Welcome back, everybody. And for anybody that's just joining us, welcome to Be the Change with Christina Bloom. And for anybody that did not hear at the start, Christina is taking today off and will be joining us again next week. So she will be back next week, Monday. And she gave me the honor to fill in for her today. And I told her I would do my best to channel my inner Christina and try not to drive away her audience in just 1 week. So if anybody has questions as we go, I'm just yapping away. So please do feel free to post your comments, post in the comments, and I will do my best to address any questions that you have along the way. So we started out by talking about pain, acute pain versus chronic pain, and then getting into some of the issues that we see as far as the challenges and difficulties, and where it's just we're not doing the best job managing chronic pain in the U.S. And it's more than the U.S. It's not that simple. Other countries are certainly struggling too. What we did see unique in the U.S. is just that our use of prescription pain medication greatly exceeded what was happening elsewhere, and was creating a lot of additional problems where sometimes the problems created by the medication was greater than the actual pain itself. And so that's much of what we were talking about. And then next, we were just talking about, okay, so how do we manage chronic pain? If not with medication, then what? And so, what I was just speaking on is that we do so by trying to increase the amount of activity that a person can do before you start feeling those higher levels of pain. So that if walking down the hallway brought, say, 5 out of 10 pain, now we want to get to where you can walk back and forth down the hallway 3 times before you feel 5 out of 10. And then we want to get to where you can walk out of the house and then down halfway down the driveway and then down the driveway around the block. And what happens with that is you really start to change your conditioning and your pain threshold. Where I talked about thinking of your pain threshold as climbing a mountain. And halfway up the mountain, you're going to if you're you're walking up a mountain, it's intense, and chances are you're not walking either. You're climbing, and the higher you go, the more fatigued, the more tired you're going to be. And if you look at that in terms of effort versus pain, the more effort, the more longer duration you're expending that effort, then it would make sense that that would often lead to higher levels of pain. So what we're trying to do is condition the person where you can do more before you feel that pain. And if we can continue to build on that, we can continue to tolerate more and more before we feel those higher levels of pain, then when we started just getting out of bed, taking a shower, doing basic things like getting dressed and just moving around your house, you're like, oh my gosh, by the time I'm done with that, I'm at 6, 7, 8 out of 10 pain, and I'm so exhausted from the pain level, I'm done. I have to take a rest. I can't do anything. And if you can then get that same person to now they don't feel that level of pain until they've gone around the block twice. Well, now you find that the daily stuff in their house, the more basic stuff, is maybe they'll say now, okay, I'm at a 3 or 4 out of 10. And yeah, I feel it. I'm still uncomfortable, but I can do that and I can function and I'm okay. And then what you try to do is essentially make their world a little bit bigger to where you can do more and tolerate more before you trigger that higher level of pain. Through that, what then you find is the things that we're doing on the regular basis or normal daily activities, you're going to start reporting a lower level of pain with that because you've now raised your pain threshold to where you can tolerate more before you feel that higher level of pain. So when you're just assessing somebody's pain, they were saying, okay, just getting out of bed and doing the normal morning routine, I was at 6, 7 out of 10. Where now I'm good all day. I can do stuff in my house, and maybe I can even work part time before I feel that level of pain. And so then what happens is your pain rating actually goes down because you can tolerate more. And you're not doing that through medication. You're doing that by really working with your body and especially the brain and how the brain's interpreting that information. And it's you have to almost rebuild a relationship and a trust with your brain and your body to where the brain says, okay, we can do this without causing significant harm, so we don't have to give as high of a pain experience. And pain very much is an experience. And another issue that comes with that is pain is so subjective. When our brain determines the level of pain we experience, it's also based on our past experience. And so brain stores all this information and it says, okay, the last time I felt a similar sensation, what happened? And a story that I had shared was an individual, he's a brilliant physiologist. He's a PT, but he is one of the leading researchers on understanding what pain is and how different ways of managing it. He's in Australia, and he had shared a story where he was out going on a hike and he felt something brush against his outer leg. And he thought, okay, no big deal, it's a scratch, and didn't think anything of it and kept going. Next thing he knows, he woke up in a hospital. It wasn't just a scratch. He actually had been bitten by a snake, and it was a poisonous snake, and it nearly killed him. And thankfully, he survived and recovered and went back to normal life. And sometime later, he was walking again and felt a very similar sensation, scratch in his lower leg. Brain gets that information, and this is instantaneous. It's in the split of a second. And the brain says, okay, last time I felt that similar sensation, what happened? And you were bit by a poisonous snake and you nearly died. So brain says, okay, we're going to make this hurt like hell. And so he said he had sharp shooting, stabbing, searing, burning pain that went down his leg. He grabbed his leg and starts jumping. And he said he swore, and he is feeling this really intense pain. And he looks, checks his leg, and looks around him and sees that at that time it truly was just a stick that he had brushed against his leg. And so a big part of our pain experience is based on what have you experienced in your life? What have you had in terms of similar situations, and what was the outcome? Was it, in his case, it nearly killed him. So brain says, okay, last time this happened, it was really bad. So we're going to send a strong message, and we're going to give us intense pain experience to protect that person, to get ourselves away from that harm that could potentially have the same outcome. The other thing too is pain's relative to what we've experienced. A young child, for instance, falls down and scrapes their knee, and the waterworks come, and it is the end of the world. I mean, the worst possible thing that could have potentially happened. And oh my gosh, the pain is so much. But then life happens, more experiences happen, and next thing you know, that same child is falling off a bike. They're falling off a skateboard, or perhaps they're an adult and they have a motorized skateboard and don't use their brake as well as they should, and end up falling and hitting the street, and really scrape up their hands. And so there can be situations like that where, as things escalate, women, certainly women that have had children, will report a very different level of pain from that experience, the pain experience of having a child. I hear so many of my patients that have had children that will compare the pain that they're feeling relative to what they recall from childbirth. And so with those higher levels of pain, you're comparing it to that as well. And it's like, okay, yeah, this hurts. It doesn't feel good. I don't like it, but it's nothing like having a baby. Or stubbing my toe doesn't feel good. It hurts, but it's nothing like being in a really bad car accident, or having a nasty fall. And I know I've broken bones, so I know what the pain from a broken bone feels like. So certainly, a scuff or a stub or a bump, I'm not going to react in the same way. So with that, we have the 0 to 10 pain scale. And then we'll look at that and say, a person comes in, they say, I'm in 8 out of 10 pain. And you look at them and you're like, really? You really think that's 8 out of 10? And then, I've had patients say that they get shamed. They get pain shamed by their medical professionals of, um, you think that's 8 out of 10 pain. If you think that's 8 out of 10 pain, you don't know anything. You were so lucky that you think that's 8 out of 10 pain. And so pain should not be judged. You shouldn't be shaming somebody. Pain is pain, and it's your pain, and your pain experience is different than anybody else's. And pain ultimately is nothing more than a message that your brain is giving you as a protective mechanism. And the next piece is just, what are we going to do with it? And the concern again is with chronic pain, is that message then sometimes just, it doesn't make sense. The level of pain that you're experiencing and feeling doesn't add up relative to what is going on within your body. And the brain actually changes. There have been some really interesting studies that have shown that when you look at, there's PET scans, for instance, are one. So it's a where you can do a scan of the brain and you get a color sensitive map where the hotter colors show increased blood flow, increased activity in different parts of the brain, and the cooler colors show less. And then knowing what parts of the brain do what function, you can then measure and get a little bit more of an objective reading on what the pain experience is. And what you'll see in somebody with chronic pain is some of the areas most involved in the interpretation of pain are at a higher level. So you can definitely see that, yes, this person is experiencing higher levels of pain, and there's actually a change within the physiology of the brain and how the brain is interpreting that information and then sending the output of pain. And then the next piece that is a huge factor in our pain is our emotional response. The more anxious we get, the more threatened we feel, the more emotional we feel in response to our pain, oftentimes the higher level of pain you experience. And that one's tough. One of the leading treatments for chronic pain is, it's called pain neuroscience education. And that's a lot of what I've been talking about tonight, is what you do for helping people with chronic pain, especially the high levels of pain that just don't add up relative to what's causing it, is teaching the individual what pain is. What is your pain? What causes your pain? And why are you feeling what you're feeling? And what does it mean? And there's been some incredible studies that have shown significant reductions in the level of pain that the person rates after they've had that educational component, just by understanding what it is. And then by understanding it's not as scary. When you find that you move and it hurts, you're scared, and understandably. To move and to try to do basic things and to feel pain with it, you're worried that you're going to hurt yourself, and that if you continue that, you're going to hurt something even more. And if you hurt it even worse, then you're going to have even more pain. And the pain's already so bad. How could you possibly experience even more? And then that will start to build on this emotional fear that comes into play, and then you become more fearful of pain. And not only fearful in the sense of the pain that you feel, in that it could potentially make it worse, but then there's an element of anticipating pain. So it's like, oh my gosh, I don't think I can even dare reach my arm to grab something on the top shelf, because I know if I do, it's going to hurt so bad. So I'm just not going to do that. And then what happens is the person starts making their world smaller and smaller and smaller by that fear of provoking pain, because if I do this, it's going to make me hurt. And if I make myself hurt, I know that when I push it, then things get worse. And then I really flare up. And then I really have a lot of intense pain. And where it becomes more than just the brain is if you're not doing that activity, if you're not reaching overhead to that top shelf, what will often happen then is the muscles are going to adapt. The connective tissue is going to adapt, and it's going to become tighter. So then next thing you know, you can only reach that far, and that's it. That's all you've got. And then you start feeling increased pain just going that far, or before you could come up here. And then you just start going lower and lower and lower and lower to where your abilities to do things become less and less. So one of the things we do in physical therapy, is using the shoulder as an example, would be to actually do some hands-on things to try to loosen up that tissue, to give you that mobility so that you can move before it pulls and before you start feeling that pain. Same thing with the back. A lot of what I do with the back is addressing the muscular tightness that you move just a little bit and it pulls. And the more you push through that, the more it pulls and the more it starts to hurt. So it's not as simple as saying, "Oh, pain is all in your head." It's an experience within the brain. It's the what the brain interprets. And if you can tell your brain, "No, I should be able to bend and I should be able to move and I'll be okay and everything's good and doesn't make sense and I'm just going to push through it." It's not always that simple. There are times where you are tight and you are restricted, and if anybody's had a tight muscle and you try to push through it, it hurts, and that's your body's way of saying stop, because it only tolerates so much before you are going to cause damage to that tissue and cause trauma. And so that's where just some of the many challenges in addressing pain, where through that, I hope that people can get a little bit of an appreciation of why it's a struggle, not only for you, but for your providers as well. And don't give up. There's so much that can be done, and there's a lot of options. And with that, it's really important that you have a good relationship with whoever it is that you're seeing to try to help you manage your pain. And one thing that I find that's incredibly important is you need to feel like you can be honest and open and talk to the person that is helping you. And you need to feel that you can share what you need to share and that you're being heard. Sometimes just being heard and being able to speak it and have somebody listen can give you a lot of relief. And that alone can sometimes help. So those relationships are incredibly important. And if you are seeing a provider where you don't feel that you can have that open dialogue, then chances are that may not be the right person for you. And certainly, if you have the luxury of other options, then consider it. Maybe somebody else will offer something more. Maybe somebody else you can have that more open conversation with and feel like you're being heard. And that can lead to a good discussion where you collectively determine what's the best course of action for you. And that's the way it should be. You should be very involved in your care. Nobody knows your body like you do. Nobody knows what it is to be you. And you should and can be an advocate for yourself and say what you are and are not comfortable with. And that's really important, that you have that relationship where you feel like you can do so. Just looking at a question that came up, we have one that says, I have degenerative disc problems and rounded discs, so my spine won't stay. I was a laborer. It took a toll on my back. Yes, that I see a lot of that. So in terms of degenerative disc problems and rounded discs, what that means is it's a good one to address, because back pain is the number one cause of chronic pain. And what happens, I mean, many people hear, we hear labels too that are tough. You go and your doctor does an MRI and says, oh, well, you have degenerative disc disease. And the person hears that, I'm like, oh my gosh, I've got a disease. I've got a disease in my back. My discs are degenerating. They're crumbling. My discs are falling apart. My spine's falling apart. No wonder why I hurt. Oh my gosh, I'm made of glass. I can't do anything. I don't dare do this because it's going to cause so many issues. And you have to be so careful with the conversations you have with people and really making sure they understand what it is and what's going on. Uh, Degenerative disc disease is not even a diagnosis. What that ultimately is if you look at somebody's spine, you'll see degenerative changes in multiple discs throughout their spine. And then we've created this term, degenerative disc disease. And it's not a disease process, it's just wear and tear. And one thing to keep in mind is that that is normal. It is normal to see degenerative changes in our discs throughout our spine, throughout our lifespan. And we'll start showing these as early as in our 20s. And just because you have that does not mean you're going to have pain. And just because you have pain, it doesn't mean that it's due to degenerative discs. The discs themselves do not have a lot of nerve supply to them. So the discs generally are not very pain sensitive at all. And a degenerative disc, what does that mean? Is the height of the disc starts to thin. So you lose height of the disc. And with that, one of the things that happens naturally through the aging process is the fluid content of that disc becomes less. So instead of being a more fluid disc that has a little more compression, a little more squish, a little more give, it becomes more dense, more fibrotic, and it doesn't have that tolerance as much. And with that, the hydration of the disc will actually become less. On an X-ray, you'll see that disc darker, and some have even called it, and it's horrible, they call it a black disc. And it just, black sounds like death when you're talking about tissue. So that really scares people too. But again, that can be a pretty normal thing. When those discs do thin, the other thing we can see is bulging. And the disc has two components. There's an inner component that has a higher water content, and that's more of a gel-like substance. So it compresses and it moves, and it has some movement from forward to back to side, so it can almost do a bit of a wedge type movement. And then the outer portion of the disc is much more fibrotic, and it's rings of dense connective tissue. And what happens in some instances is those outer rings, you start to tear through them from the inside out often. And as that happens, the wall of the disc will become a little bit weaker, and it allows that more fluid, more flexible component on the inner portion to start to migrate outward. And as it migrates outward and puts pressure on the wall of the disc can actually start to bulge. And over time, you can tear through more and more of those layers where it bulges more and more. And the interesting thing about our design is where the disc is actually its weakest in terms of the wall, it's right where the nerve exits. So if that disc bulges enough, it can start to put pressure on the nerve. And that's when you get a pinched nerve. And then can start feeling more intense nerve pain down the leg or down the arm if it's coming from the neck. And then the next thing that you may have heard of is a herniation. A disc herniation is where that outer layer of the disc, of those dense connective, those rings that go around, if the person actually tears through all of them to where that tear is from outside inward, then that content that has the higher water composition can actually migrate outward and come out of the disc space. And then if that comes in contact with the nerve, the pH is actually different. It's a chemical irritant, and that really irritates the nerve, and that can cause a lot of nerve pain. And that's one of the issues then that will lead. That's one of the most common reasons why a person would ultimately have surgery. And that occurs mostly in the 40s to 60s. Once people get beyond that, then it changes. And it's not so much often due to disc herniation. It's often just that the disc itself has thinned and become more fibrotic. And the thinner that disc gets, the closer the vertebrae come. The closer the vertebrae come, the smaller the hole is at the center where the nerve comes out. And then it's easier to irritate that nerve and cause more nerve pain. And so that's one of the big factors that people are dealing with chronic back pain, and especially when you do have those X-rays, you have those MRIs, and they say, okay, yeah, you've got arthritic changes, you've got degenerative changes in the disc, and that doesn't always mean that you're doomed or that you're condemned to have pain for the rest of your life. It's not that simple. There's a lot of other factors that go to it. So if anybody is having back pain and you do have that MRI, you do have a CT scan, you do have those X-rays, and you hear these things, try to not lose hope and think that it's an end all be all and that there's no hope for you. That is very rarely, thankfully, the case. Looking at some other comments here. Courtney had said rubbing over it, I believe, waking up the tissue. That is something too where you can have some hypersensitivity along the pathway of that nerve. And then, for instance, the low back. What I'll use as an analogy is think of a lamp, and let's say the light bulb is your foot, and you're focused on the foot pain. That's your light bulb. However, if you're having an issue with your lamp, it's not always the burnt light bulb being burnt out. Maybe it's not plugged in, or maybe your dog or your cat chewed on the cord, and the cord is the issue. Well, the cord's the nerve, and the cord plugs in, and the outlet, the wall is your spine. So you can have an issue anywhere along there, and there's a feedback communication where you can have bottom up and you can have top down, and both of those will influence what you feel. And so sometimes just that area it's irritated, that nerve, that cord is really sensitive, and then anywhere along there, if you rub it or bump it, it can really send you a strong pain response. And then there's a whole lot of different things we can do with that too. There was another comment about sweet potatoes and carrots. Sweet potatoes, carrots and beets are good for disc issues. Sounds good. Sweet potatoes, carrots, and beets all sound great. They're good food too. So I'm not familiar with what the use of that for pain, but it sounds like it's a naturopathic remedy out there. So certainly something to look into for anybody that's interested. Another person commented that I get pinched nerves and muscle spasms. My doctors say there's nothing they can do. And I am hoping that that's not true. When it comes to your doctor, your medical doctor, there are limitations to what they can do, certainly within what they do. So doctors typically they're managing your care. They're prescribing medications when they believe it's appropriate to do so, or referring you to other options. But are they going to do hands-on things and work with you directly to do manipulation and things to try to manage that? No, that's just not what they do. That's why we have chiropractors, physical therapists, massage therapists, Reiki practitioners, reflexologists. There's so many great options out there, and hopefully they're also connecting you to some of those options and giving you some insight on other things that you can do to look at managing it. And a lot of times, people we don't want medication. I hear from so many of my patients, I don't want to take medications, so that is certainly another thing that's important in that relationship with your provider, that you can have that discussion and then learn what your options are. And that actually takes us right to 9 o'clock. So I have yapped at you for an hour straight. So I hope I've shared some information that was helpful for you all. If you have any questions, certainly feel free to reach out to me directly. And just to let you know, Christina will be back next week. So next week, Monday, she'll be back, and she is going to have a guest on the show. Her name is Sharon Madsen, and she is going to be discussing nutrition and aging. So I'm sure it's going to be a really great one to attend. So at that, I hope you all have a wonderful evening, and thank you for joining us.
The truth is here and now on WLTK-DB Talk Radio at WLTK-DB.com.